You're listening to National Health Executive's Finger on the Pulse podcast with me, your host, Saskia Hicking, here to guide you beyond the headlines with news, views and insider truths from across the healthcare sector. Hello and welcome back to another episode of NHE's Finger on the Pulse podcast. Today we will be focusing on the integrated care system restructure as well as the future of mental health services in an ICS setting. I'm joined in that discussion by Alex Church, who is currently based at Norfolk and Waveney Clinical Commissioning Group as a Senior Programme Manager. He's also leading on the development of improving access to children and young people's mental health services. Thank you for joining me today, Alex.
Thank you.
I'll start off by letting you introduce yourself. Just tell us a little bit about your background and how you got to where you are now.
Okay, thank you. So I started off as a consultant. I was working across Bradford Clinical Commissioning Group and Bradford District Care Trust. So I was Digital Innovation Lead for the Care Trust and Children and Young People's Transformation Lead for the mental health services at the CCG. Prior to working with the NHS, I've run a voluntary community sector organisation since 2010, so helping young people from disadvantaged communities get into employment and use creative kind of music and creative industries to help them with furthering their potential in life.
And obviously we've discussed this, but you have an interest in the integrated care system and how mental health services will be affected within that when we do eventually get that change. I know it's been postponed a little, but we will get there eventually. Start off, how do you think an ICS way of working will support in the transformation of mental health services?
Well, I think it'll improve communication between health and social care, first and foremost. I think it'll allow different voices at the table, so it'll improve the voluntary community sector voice around the table. It'll make sure that decisions are being made collaboratively with different stakeholders rather than kind of health developing a piece of transformation work, children and social care, or adults social care are making a decision over there and it's not joined up. And I think it'll help with commissioning as well. Strategic commissioning boards and panels set up, enabling finance to be used better. So I'm really excited by it. Obviously it's emerging. There's a lot of different things to go through at the moment to understand it. I think it's a little bit misunderstood by a lot of people because it's an emerging thing. It's a huge different way of working, and I think when you've got different age groups, so you've got people just coming in starting with the NHS and they might embrace it, but you've got people who are ending their career as well with health and social care and the impact it has on them.
You've spoken about some of the benefits of going to an ICS system, and what are some of the challenges that you think moving into an integrated care system may have?
Well, I feel that it's understanding what it actually means, but how you've already got established pieces of work happening. You've got long contracts happening among providers, and suddenly you're asking people to change their governance structures. You're asking people to start to think in different ways of work. Instead of thinking about place-based as much, we're going into regional based, which I think is really positive, because one thing I found with the benefits of ICS is that you may have a piece of work that's happening in another region, and now you'll be able to understand that piece of work more because people will be talking to each other and going, oh, we've set that up over here. It'll avoid duplication of work and things like that. Commissioners will start to speak to each other more and start to say, actually, what you've done over there, that could work for our health population. Why don't we try that as well? And I think sharing best practice, better communication, I think it'll be really, really beneficial. Some of the challenges will be that a lot of the workforce are used to working in a certain way. A lot of commissioners are used to working in a certain way. There's a lot of fear among the workforce at the moment that what I've seen when you talk about ICS. Are we going to lose our jobs? Is there going to be one commissioner for 2 or 3 different areas and we'll lose that place-based? How will an ICS understand local need? Because local commissioners understand what's needed for their local health population. When you start to share that amongst different people, will the offer become diluted? How will we be able to make sure that place-based commissioning still happens, but we also benefit from a wider understanding of what's happening across the ICS patch, if you like.
Yeah, and obviously, like you say, there is the danger of that, people feeling that they're a little less in control. But I think the whole point of the ICS system is to hand control back and put it in the hands and say, if this is what your community needs, then this is what we'll spend it on, and then this is how we'll work. And I think hopefully that's the effect that it will have. And you spoke a little bit there about not repeating other work that's already been done that could just be transferred over from trust to trust or group to group. What are some of the things that you're working on at the moment?
So one of the main pieces of work is an integrated front door into children and young people's mental health services. So Norfolk and Waveney are currently responding to the needs of the health population. You know, they've listened to children and young people, to professionals and parents who've overwhelmingly told them that accessing to children's services is difficult. If you talk about primary care, for example, primary care often say, you know, we don't understand what the offer is locally, so they will default into CAMHS more often than not, and CAMHS will look at the referral and say, sorry, that doesn't meet our threshold. They'll then reject the referral, and then it's the young people who suffer because they desperately need that help, and it's not available for them at the right place at the right time. You know, across Norfolk and Waveney, we're looking at an integrated front door, so one front door into services using digital technology, using machine learning, elements of artificial intelligence to help understand what referrals are coming in and make sure that the thresholds are met by offering, whether it be counselling, early intervention, digital offer, specialist support if it's needed. But I think it's really important that when we're developing a piece of infrastructure like that we're looking at the referral pathways, ensure that our services are appropriately resourced, and that's where you get your VCS. So I think this is a really good example of how an ICS can help, because Suffolk, they want to develop something like this. Cambridge, Hertfordshire, lots of different areas are talking about doing this. So this is where an ICS way of working, you develop a piece of transformation, innovation, and then you talk to the other areas and say, look, we're doing this. Why don't you take from our learning? I think that's an example of how an ICS can work, because otherwise you'll have lots of different areas doing lots of different things.
Yeah, and it's a lot of saving time. Time is precious, isn't it, at the moment? I mean, it always has been, but now so more than ever. And I guess resources and staffing are stretched. And if in any way we can help that and, like you say, bring almost everything under one roof and have it collated in one place, then that has to be a benefit to us all, really.
Well, yeah, and I think you know, there's an NHS ambition that in 10 years' time there'll be more digital first offers. And I think if you take digital transformation, for example, there is a mixed feeling about digital transformation among clinicians, and you know, the impact of, is it safe, is it secure, how can we use it? I think an ICS can help us digitally mature our workforce. You know, from my perspective, digital doesn't work without an appropriately trained workforce there to work alongside it. Digital's not there to replace any workforce as such, it's there to enhance the workforce, to help the workforce become an intelligent health system. And I think this is where ICS is. They can really, really work on lots of digital innovations in the area and send it out and help areas to educate themselves utilising digital. I think that's really an important point to make.
Yeah, and I think it's a really interesting point that you made there about having the staff on board. And by the time this podcast goes out, we've got a really interesting piece about Medway Trust introducing their EPR system and how they trained the staff on that. The staff were really involved. There was nurses who had been trained within the system and were out on the wards helping them use it in every day. Yeah. And I think that, like you say, is so important that everybody's on board.
I think digital is here to stay, but it's just about making sure that the products used are safe, they're ethical, you know, they meet the clinical guidelines, and that there's a language between the developers and the clinicians that they understand. You mentioned EPRs for the voluntary community sector. This is a huge issue because voluntary community sector organisations that are commissioned flow to their MHSDS systems, and we forget sometimes that voluntary community sectors are very, very small. They don't have a large infrastructure, they don't have an IT team, they don't have data analysts on board. How can we, utilising an ICS, help share knowledge around EPRs, around interoperability between digital platforms and things like that?
And I know obviously we haven't made that transition fully to an ICS yet. And do you think it's been difficult during the pandemic, or do you think people have taken it in the stride?
But personally, I obviously I can't speak on behalf of everybody in the NHS, but one thing that the pandemic has helped us to do is work differently. is to adopt different ways of working, change some of the rules, lighten some of the rules sometimes, especially in terms of remote working, working online, offering clinical support online and things like that. Obviously, we always work safely and ethically, but I think trying to bring in an ICS in and amongst this, I'd say I'm torn between saying I think it's a really good idea, because I think people have been ready for change. People are embracing change at a very quick rate. So why not bring this in at the right time? Now, obviously, I'm speaking on behalf of me being in a commissioning team here, not on a clinical role. If I have to spare some thought for colleagues who have been absolutely flat out on the front line doing clinical work all the way through the pandemic, and then if I was to ask them, or if they were to hear me say this, they might have a different story about how they feel about turning to an ICS and what that means for them on the ground. There's different departments in the NHS, and some of them, I would imagine, would welcome the ICS and say that the pandemic's helped. There's other areas that say, actually, we're flat out here trying to deal with the pandemic. Don't throw this confusion into us now.
Definitely, and obviously your feelings towards an ICS way of working will be very different, like you say, to the team on the front line. And like you say, perhaps that 3 months as a delay almost is because of that, and it is taken into account the pandemic.
Yeah.
Last thing you want to throw at them is a whole new way of working with digital innovation mixed into there, and especially like you say, if they're not used to a digital way of working, then that's a whole new kettle of fish to undertake, really, isn't it?
Yeah, and I think, my role is very transformational, so I have to try and set groups up, set meetings up in and amongst clinical activity. So, I'm the one in the room going, let's change this, let's try this, let's try a different way of doing this, and that can be met with, yes, that's brilliant, let's try that, or some people say, oh, let's just calm down here a little bit. You're dealing with different levels of personalities and different experiences in the room. I'm personally excited about an ICS way of working. I think it's taken me a long time to really understand what it'll mean, but I can see in my work, especially around transformation, that an ICS will unlock lots of potential.
And you spoke a little bit about saying it took you a while to even understand what it means. There are a lot of confusion between, terminology to do with ICSs and ICPs, and how have you gone about kind of busting the jargon within that, and how do you think other people, especially I guess people on the front line, how would you put it across to them?
The way I kind of break it down in my own head and try to explain it is that the ICS is the coming together of the region or the different areas, whereas the ICP is your local place-based group, and that feeds into the ICS. Some people will turn around and say, well, there isn't going to be much change. The ICPs become the new CCGs. There's more of an emphasis on working together, and I think that is the key for me, that we avoid these silo working practices, and an ICS will help us to communicate with each other more and not see complete system rather than independent pathways, and everybody has an equal voice in it, and this kind of toing and froing between health and social care and your VCSs shouting at the bottom going, please listen to us, we're here as well. These ICPs will create an opportunity for all the voices, hopefully, to be heard, and then these ICPs can then feed in to your ICSs. I think from a very senior level, some positions will go into one ICS, so there may be one commissioner who feeds into the ICPs, but each area still has to have its own place-based strategy, because otherwise it wouldn't work very well.
And as well, you said about different services, and it's almost like the ICS structure is almost bridging this gap between the different services between us, and like you say, connecting the voices and letting everyone be heard. But what do you think statutory and non-statutory services, do you think they could form better relationships through this?
I think NHSE, speaking from documents that NHSE are releasing, that areas are being asked to improve relationships with non-statutory services, but I think many areas are demonstrating that there is an excellent relationship between statutory services and the voluntary community sector. Bradford is a shining example of that. I think Leeds are doing really, really well with that, and Norfolk. So I think it's not new that statutory and non-statutory need to work better together, but it's just the statutory services that have got huge infrastructure and they've got different teams that they can attend all these meetings, they can be there, and sometimes voluntary community sector needs to think really hard about, can we release a member of staff to go to that meeting, because we can't afford it. We're on a shoestring budget here. I think there will be voluntary community sector forums. There already is VCS assemblies in each area. Just improving the governance. That's a key thing. I think in a lot of areas sometimes the governance needs to be strengthened.
And obviously we spoke about getting everybody involved in this, and you need the backing to make this successful and to make it run as smooth as possible when we do fully transition. Is there anything that you'd say in terms of getting everybody on board and kind of promoting that it is a positive change and it will work for the better of health services as a whole?
I think the best way to demonstrate that is for areas. Obviously, areas are transitioning from their old governance structures into the new. That's what's causing the confusion. And I think demonstrating to people from a local perspective, how will this improve my work? How will this improve my job? How will this improve my prospects at work? And how will it improve the impact that we make on our health population? That's ultimately why we do this work. Is this going to be a positive or a negative for our clients and our patients and the people we want to serve? Because that's ultimately why people choose to work in the NHS, or more often than not, they choose to work in the NHS because they want to make a difference to people's lives. So how can we show that an ICS is going to improve the difference that our kind of clinical pathways make to people's lives? I think that's if we can show that, and if we can get that governance right at an ICP level and an ICS level, then we're on to good things. And I think language as well, abbreviations, what do they mean? People releasing a directory might help, because people make their own assumptions about what things mean. I might have made my own assumptions about what things mean in this meeting based on my own subjective thoughts. If I read a document and it tells me about the ICS and the ICP, I'll form my own opinion of what I think that means, and then the next person will form their own opinion, and then all of a sudden you've got different people thinking different things about what things mean. And I think being very, very clear from the top down on how this will work. I think another thing I've seen is that there has been a fear. I've mentioned this earlier about people losing their jobs within this, and some areas have guaranteed the workforce, some areas have said there'll be changes, some people are going to be redeployed. So there's a sense of anxiety among some of the workforce around all this and what it means for them. Some people are quite happy in their job and they're quite structured in their job, and some people are quite resistant to change, and those people, I would imagine, would find moving to an ICS quite an anxious situation. Other people love change, other people embrace change, and so you have to think about there's different people who treat this whole transition very, very differently.
But ultimately, like you say, the NHS has been the way that it has been for decades now, and I guess any sort of change to the structure, and such a large change like this is bound to potentially ruffle a few feathers in some places with people, and if it's not clear, then that's when anxiety is caused. But ultimately we need to look at this as a positive change, and it's for the greater good of consultants, clinicians, nursing staff, HCAs, everyone, but also patient care as well.
Yeah, I think ultimately there are people who will be pro ICS and people who will be still trying to make their minds up, and I think we need to help them understand what it's going to look like. But when we're in an ever-changing environment, and it's the structures do change slightly, and the messaging changes slightly as well sometimes around what's going to happen, when it's going to happen, delays and things like that. So that does increase the slight tension among people.
I'm conscious that we've gone on for a while now. We might lose our listeners' attention here, but is there anything else that you wanted to add in terms of the work you're doing, or anything that you wanted to voice and share with people, or anywhere that they can find any resources or contact you?
I'd just like to say, if anyone wants to talk to me about their thoughts on the ICS or anything like that, or I'm happy to share learning about any of the work we're doing across Norfolk, any of the work I've done elsewhere, because to me, working together, building relationships, we're all one NHS. We don't break down into areas. We do break down into areas, but I don't see that. I just like to help people. If my ideas can help reach young people, reach adults onto the ground, that's ultimately why I do this work. And if anyone's heard anything here that they want to know more about or whatever, please get in touch.
Thanks for listening to this episode of NHE's Finger on the Pulse podcast. Join the conversation on social media or get in touch through the link on our website to stay up to date with all the latest news and episodes. Make sure to subscribe and drop us a rating on whatever streaming platform you are using. Thanks for listening, and we'll see you next time.